Thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Abby Espinoza, the Program Manager at CSCLA, and I'm honored to welcome you to this week's webinar titled A Guide to the End of Life, A Nurse's Perspective. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. Please enter questions for the speaker into the Q&A feature found at the bottom of the Zoom window. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but we'll get to as many as possible. Please use the chat feature to share comments and resources with other participants or to ask questions of CSCLA. We ask you to limit chat comments to information relevant to this topic. Sarah is an oncology care coordinator with 14 years of experience in inpatient hematology-oncology, inpatient hospice, and nursing education. She has published articles on a wide variety of topics, including interdisciplinary collaboration, nursing quality indicators, and geriatric issues. Sarah is passionate about supporting patients through the entire care continuum. It gives me great pleasure to welcome today's speaker, Sarah Lowe.
Hello, my name is Sarah Lowe. Thank you so much for having me. I'm so honored that you would spend your lunch hour with me. So today's talk is going to be a guide to the end of life, a nurse's perspective. This is originally a part of a three-part series, which included a social work, dietitians, and end-of-life doula. And those are available and already up on the CSCLA YouTube website. So please look into those. Those have some really great wisdom there. Also, this talk isn't going to be focusing on like the code statuses, advanced care directives, post the End of Life Care Act, those sorts of things. But CSCLA does have a really great talk geared towards those topics. It's called Your Life, Your Choice, Discussing End of Life Choices with Karen Warren. So I'd like to direct you to there if that's something that you would like to know more about. This talk today is going to be looking at an overview of the role of palliative and hospice care, as well as their distinct differences, review symptoms that may occur during advanced stages of cancer, and the interventions that may help alleviate those symptoms. I'm also going to provide an overview of a general timeline of symptoms that occur during the weeks, days, and hours before end of life. There's no graphic photos in this presentation, but if for any reason there's anything triggering, you can always feel free to close out this webinar. It will be posted up on the CSCLA YouTube page. Okay, so I would like to start by recommending a really wonderful book called A Beginner's Guide to the End of Life by B.J. Miller and Shoshana Berger. This talk correlates specifically to two chapters in this book called Dynamic Duo and Symptoms 101. And then I've also added my own input brought in from my own experiences. And I just want to start out with this quote, which is, "There is nothing wrong with you for dying, but you never know it from the way we talk about death. We actually call it a failure. Her health is failing. He failed treatment. If you believe what you read, the entire enterprise of aging is optional. Eat kale, drink red wine, walk 10,000 steps every day. If we can't beat death, then clearly our character or will or faith isn't strong enough." And what about all those fighting words? Beating death, defying aging, the war on cancer. All battles we're sure to lose. Next to birth, death is one of our most profound experiences. Shouldn't we talk about it, prepare for it, use what it can teach us about how to live? We don't mean to suggest that you or anyone can take the reins and control how all of it is going to go. Part of the challenge is tempering that need for control. Death as a subject is not easy, and dying is not painless. We make no promises to the contrary, and we encourage you to run from anyone who does. But we do believe this book, and I like to think this talk, will help dying be less painful and more meaningful. So this talk is really centered around looking at the realistic options that we have. And often when we talk about realism, especially about the end of life, it can feel like something very dark and dire. But what I am offering is hopefully a very different perspective. This is a personal philosophy of mine from personal and professional experience, not evidence-based. But I truly believe that one of the best things we can do when looking forward at advanced disease and symptoms related to advanced disease is to embrace realism. And I do want to say that I am actually somebody who believes miracles are possible, which is a funny thing, I think, when I am telling you right now that I want you all to embrace realism. But what I mean is that we want to start from a place of what do I know? What do experts say? And what can I gain from them? What do we know or know in terms of science? That way we can start from a place of acceptance. That's not an easy thing, and neither is the next ask, which is to embrace flexibility. We have to be willing to look at things differently. A lot of things we can't necessarily change or fix, but often different ways of looking at things and trying new things can be very powerful. We all have this intense need to hold as much control as possible. And yet, a lot of this process, like the last quote mentioned, is about learning to let go of some of that control. And I think that when we start with realism and flexibility, then those two are put together. What I think we get is a very fruitful optimism. And I like to contrast fruitful optimism with something that I sometimes see and that you might have heard of, which is toxic positivity. Um, Sometimes we see patients who want so badly to harness that power of positive thinking that it can actually become a tool for avoidance and denial, and at times can even become harmful. But I think if instead of going into that direction, we actually combine realism with flexibility, we have the ability to be optimistic in a way that is really fruitful and can make a change. So I'm going to talk really quickly about palliative and hospice care. They go together like cookies and milk. We now have an abundant research that shows that patients who receive palliative and hospice care experience less depression and anxiety. And they also show that palliative and hospice care doesn't shorten life. It can even prolong life. That was something that was a concern when, when hospice and palliative care services began to be introduced. So that was really great that the research demonstrates that. But palliative and hospice care are very distinctly different, and I do want to really touch upon their important differences. So palliative care is a specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of illness. The goal is to improve quality of life, and it is meant to be holistic to include both the patient and the family, which is a really great part of palliative care. Uh, it is very distinctly not about the end of life because palliative care and hospice care rose up in the ranks at the same time. Many people have a concept of putting palliative care and hospice care together and associate palliative care with the end of life. And because of that, a lot of institutions, including Cedars-Sinai, have actually rebranded. We no longer call our department the palliative care department. We call it the supportive care medicine department. And that is a way that we can emphasize that the point is symptom management to be supportive, that it can be started at any time. And we actually encourage early connection to palliative care. There was actually a season of time where at Cedars-Sinai, as soon as a patient came in to our bone marrow transplant service, they would be automatically given a supportive care medicine referral. We can't do that anymore. We don't have the bandwidth to handle that, but that's the concept. The concept is we start early and the service can provide support all throughout that patient's cancer treatment and care continuum. And we really encourage it because we have so much research demonstrating that patients connected with palliative medicine have, like I said, less depression, less anxiety, and also have less interruptions in their treatment schedules. So, a doctor may say, okay, I recommend this regime. It's going to be this many cycles for this many days at a time. And this is the dosage that we are hoping for. Patients who have palliative service is on board, they have a tendency of completing that recommended treatment regimen in the time that was recommended and in the dosages that were recommended. So they don't have to stop treatment as frequently or lower the dosage because of side effects. So we see a lot of benefit that can come with patients being connected. So now that you understand the point of palliative care being symptom management, you can see why palliative care is super important at the end of life and a very important component of hospice, because at the end of life, we really, really care about symptom management and we care about quality of life. But it is very distinctly different from palliative care. So let's talk a little bit about hospice. So hospice provides physical, spiritual, emotional support for those with a life expectancy of 6 months or less, with the goal of increasing comfort and provided where you live. There is nothing magical about the 6-month mark. It's just this arbitrary number that politicians thought sounded good. And a person can be re-enrolled indefinitely every 90 days. So you can be on hospice for, potentially much longer. But what hospice provides is resources, and it is considered its own insurance. So if you go into hospice, then you would disenroll from your current insurance and enroll into hospice. It is legally required to be available to anybody who has insurance. So if you have insurance, hospice is an option. Um, one of the things to mention is that there are, in places in America, there are some things called hospice homes where patients can actually go and be admitted to these homes and receive care there at the end of life. That's not really an option for us in California because our property taxes are so high that we just don't, the hospice homes can't really function. And so hospice is almost certainly going to be home health, like they will be coming to your home and coming to visit you once or twice a week, and trying to support you. There are just a very few hospice homes that I know of that run in California in more rural areas. So if that is something that you're interested in, I would take a look at that early. Hospice is meant to be holistic and include the family, which is really wonderful. Like they will also provide care for the family. It is something that I recommend considering early because most people wait unnecessarily long. 1 in 3 patients enrolled will be only enrolled for a week or less before they pass. For some people, that's the perfect amount of time. For many people, they really could have benefited from the resources much earlier. And considering early also allows you to do more research and to do informational interviews and just find the best fit. like anything else in this world, it's not a magic bullet. It's not going to necessarily make everything better. There can be, mismatches. So getting that information can all be helpful. Uh, the other thing that's important is that you do want to be prepared to forego curative treatments. So if you are on hospice, clinical trials or radiation therapy, these things are no longer going to be available. But that is very different from the things that would still improve quality of life. So what I mean by that is if you have somebody who has a lot of back pain, perhaps a back fracture, um, we probably wouldn't recommend a kyphoplasty. It wouldn't be covered by hospice because that has a recovery rate, besides a very invasive surgery, a recovery time span of 12 to 18 months. So for somebody who has a potential lifespan of 6 months, not the best use of our resources, not necessarily the best thing for the patient. What we will instead do is really focus on getting control of that pain through pain medication or other means. Um, that is in contrast to, say, somebody on hospice getting a UTI, a urinary tract infection. Well, that is going to cause discomfort and pain, urinary frequency, all sorts of things, and fever. Let's give them antibiotics so that they can be more comfortable. Okay, so here are some of the resources that hospice can provide. There will always be a hospice doctor who's overseeing care. You are most likely, though, to interact the most with the hospice nurse, who is the one who comes and visits the home. There can be a hospice aide that can provide bathing support or simple things, social worker counselor, chaplaincy. Volunteers can sometimes be available to help with your grocery runs or simple things around the home. Physical, occupational, speech language therapy can be provided unique to the patient's needs. A grief counselor is available for up to 1 year after someone passes, which is a really great benefit that many of our patients' family members will utilize. Basic supplies and durable medical equipment get much, much easier to obtain. So I've had a number of times where we're just trying to get the right orders and the right documentation and all the things lined up to get patients something. And then we see that the patient has gone on to hospice and we're like, okay, they're going to get everything that they need. We're not worried about that anymore. So that's a big blessing. 24/7 telephone support. Respite stays, I actually haven't seen this myself, but I do know that there are hospices that can provide some respite support for caregivers, prescription support, definitely. Around the clock nursing care for a day or two is also something that I haven't seen myself in practice. What I have seen more commonly is that as death becomes near and everybody is recognizing that, the hospice nurse may come more frequently and then maybe even start an IV because the patient may not be able to take oral pain medication or it's not providing enough support, and then, be able to provide extra support. Okay, so some things that I want to talk about, which is that for symptoms, most discomfort is treatable. It may not be fixable. However, we will try, but we might not be able to fix. But that doesn't mean that we can't help. And there are many things that we can do to alleviate. And we want to think about how symptoms can be acute or chronic. Now, acute symptoms are brief and severe. That's something that happens. You want to let someone know. Maybe an visit is warranted, and they'll see, have some intervention. Chronic symptoms are those that persist over time, and they persist despite the fact that we are trying to do what we can to get rid of them. And as frustrating as it might seem, they don't necessarily warrant an urgent response. A visit to the emergency department isn't necessarily likely to move the needle very much. And some of the side effects that can come with having these chronic symptoms is a sense of hopelessness and frustration. And that's where, we ask for considering that lens of flexibility and considering that even if we can't get rid of something, maybe we can do something to help. And when something is chronic, one of the things that we do have then is time. We have time to get to know you and those symptoms, time to experiment and try different things. And I am going to be talking about some of those different things that we can try. The other thing is that you are the best judge. You are not a statistic. You are an individual. And just like I am so confident that nobody here has ever met somebody who has 2.5 kids, even though that's supposed to be the average amount of kids that the American family has. You are the only one who can say if something is or is not working for you. And that goes into the fact that one of the best researched physiological effects that we have is the placebo effect. And we know from so much abundant research that a certain percentage of people will respond to placebo medications and have feel relief from different symptoms. And we have this really fascinating research that looked at giving patients either a pain medication or a dummy medication. And there was a certain percentage of patients who received the dummy medication in which their bodies actually created their own natural opiates in response to that dummy medication. And when the researchers talked about it and they were interviewed about it, they actually described it in what I thought was a really beautiful way. They said that a placebo has the possibility of triggering the body to heal itself. That's all to say, like, the placebo effect is amazing. If things are working for you, even if we don't have, the most robust scientific information behind it, and it's not likely to hurt you, and you've talked to your doctor about it, then, please, by all means, please do those things. Something else that's important is that medications can cause other distressing symptoms. We have a problem in healthcare where we prescribe a lot and then we don't unprescribe very much. And so people can have enormous medication lists that have never been pared down. Palliative care and hospice teams tend to be much more conscious and mindful about the importance of paring down medication lists. And that can be a big benefit. So I invite you to definitely consider that as you are navigating your disease. I also want to share that we are very aware in our healthcare system that we are very Western-based medicine, and we do not have knowledge about everything that is possible. And not only that, not everything that is possible is going to be well researched because there isn't necessarily the funding or the interest in funding these things. So there are alternative treatments that people will want to be interested in. And in fact, 80 to 90% of people actually report using alternative treatments, but only 30% will actually tell their physicians about it. And so this is where I ask you to please, please, please tell your physicians. I have actually never really seen an oncologist be adamantly against someone doing alternative treatments unless they had a good reason to. If anything, I've seen like dismissive or indifferent responses where they're just kind of like, okay, if you want to, sort of thing. But there are things that we do know. There are things that we know can be dangerous. So we want you to please tell your doctor. An example of something that could be potentially dangerous was a situation where I had this patient who went through a very difficult time going through chemotherapy and then going through a stem cell transplant. And we finally sent her home. We were so happy. And then she came back in 48 hours with raging sepsis. And she had eaten something at home, which was a delicacy, which was a not fully grown raw baby chick. And in like 99% of circumstances, would have been completely fine. But in that like 1% of circumstances in which she was severely immunosuppressed and neutropenic, it almost killed her. So that is something that we just know. The other thing I want love you to keep in mind that in talking about the various alternative treatments that can be considered, I am casting a very wide net because these are things that might not all be very well researched. And some of these are anecdotal, but they're also not likely to be harmful. And so, some patients say that it benefits them. That's why they're on this list. So let's talk about anxiety and depression. So anxiety is an overall sense of worry or fear or difficulty concentrating, restlessness. Depression is lethargy, having no interest, feeling hopeless. And a certain amount of anxiety and depression is actually considered normal in advanced disease. But it can be from things that you might not expect. For example, there's a lot of boredom and frustration that is involved with all the waiting and uncertainty and just like the difficulty of our healthcare system. Um, and the fact that managing a illness is a full-time job, and what can happen is that we end up inadvertently cutting ourselves from the things that actually give us joy and give us life. So medications can be very helpful. There's all sorts of things that I'm going to present, but sometimes what can be just as helpful is just putting yourself back in front of the things that you care about and reconnecting with the people you care about as well. So here are some options that we've got. Herbal and non-pharmacological counseling can be a wonderful resource. Distraction, meditation, breathing exercises, guided imagery, physical exercise, which by the way, physical exercise has the same rate as medication in its likelihood to improve anxiety and depression. And it can be adjusted to whatever you are at physically can do, and it's free. So it's wonderful. Energy healing techniques, music therapy, animal assisted therapy, massage, acupuncture, craniosacral therapy. Craniosacral therapy is a gentle hands-on technique that uses a light touch to examine membranes and movements of the fluids in and around the central nervous system. This is one that doesn't have a lot of research behind it necessarily, and there are some people who think that it's kind of pseudoscience-y, but there are patients who have found it really useful. And if it's you, please do it. Essential oils that have been known to be helpful: lavender, citrus, clary sage, bergamot, ylang ylang, and even some herbs like milky oat seeds. And then we've got some really wonderful medications that can help: antidepressants, benzodiazepines, psychostimulants, and cannabis. And when we talk about cannabis, I do want to ask you all to please tap into your community, the cancer community around you, like the cancer support community of Los Angeles, because cannabis itself is an unregulated product at this time. And because of that, that information from others about growers or providers that are providing safely grown products that know what kinds of strains provides what sort of effects. Not all cannabis is made equal, and it does have some wonderful potential, but it still needs to be taken under the supervision of a physician. So please keep those things in mind. Confusion. This is when someone is unaware of themselves, person, place, where they are, or the time of day. And it's actually very common in the hospital where you're in an unfamiliar environment where sleep wake cycles are completely disrupted. And there can be many different sources for it. Um, and if we can identify a source, we can actually make a huge difference. Like if it's infection, then we can provide antibiotics potentially. Um, if it is, a hypoalbuminemia, so you've got too much of albuminemia in your blood, then we can do something about that. Um, there are, however, sometimes where confusion becomes more common and becomes a part of the advanced disease and dying process. So just to be aware of that, that our doctors still want to know because we want to try to identify and reverse anything that can be reversed. And even if we cannot reverse, there's still things we can do to help. Um, with confusion, it's often waxing and waning in that it comes and goes. Like I said, very common in the hospital. It tends to worsen at night. And when that happens, we call it sundowning. And we also see it in a hypoactive state where patients are less emotive and less mobile. And families really tend to be the ones to help notify the healthcare providers about it. And sometimes patients don't really want to tell their family members or providers that this is happening to them. But what I want to say is that confusion, delirium is nothing to be ashamed about. It's actually very normal. And we want to know and do something about it. Okay, so what can we do? Here are some options. Uh, some very basic and very disciplined. You do have to be very consistent about supporting sleep-wake cycles in terms of that can make a huge difference. Reorientation, that can be having a window with the curtains open so that you can see the sunlight and the darkness. A clock to provide reorientation to time. You can reorient by talking, having a casual conversation with a loved one, talking about familiar people and current events. And even if some of the responses are confused, don't give any strong reactions. Just kind of go with it and go back to those grounding, reorienting topics. There are also ambient essential oils like rosemary, vetiver, citrus, and basil that have been known to be helpful, and craniosacral therapy, animal assisted therapy, acupuncture. And there are medications as well, although we do need to be careful because some of these medications can have the effect of a worsening confusion, and so our doctors will be very judiciously using those medications. Constipation. So, constipation is a source of a lot of distressing symptoms like pain, nausea, loss of appetite, shortness of breath, fatigue, and confusion. And it can also be a medication side effect. It can be because of immobility, nervous system dysfunction, dehydration. And almost everyone tends to underestimate the potential impact of constipation. I think especially because you're like, I'm not eating as much or something to that effect. You don't think it's really a problem. But even if you are not eating, your body is naturally sloughing inside of the mucosa lining, and that sloughing needs to come out. So we always have the goal of going to your normal bowel habits before getting sick. That's always the goal. Um, and so we want to be having regular bowel movements. So what can we do about constipation? Oh, and I should share that because I am a big proponent about catching this early and doing something about it. So I always ask my patients, stay hydrated. And if you get to like day 5 and you've escalated in the laxatives and you've, made sure you're well hydrated, you're moving around if you can do that, doing all the things, then on day 5, you still don't have a bowel movement, go grab an enema from the drugstore. And if you're not comfortable with that, go to urgent care and see if they can do it for you because you have too many other things to worry about than to have constipation causing more problems. So kind of like I discussed, hydration, warm water with fresh lemon or lime juice can be helpful, chewing fennel seeds, mobilizing as much as possible. Abdominal massage, there is a technique where you start from the left side and you massage upwards into like an I shape, upwards I, and then you make an L by going across. And then you come down on the right side to turn it into a U. So they call it the I love you method. But that's a great kind of massage to help things move in your abdomen and your intestines. Acupuncture, acupressure, reflexology, prune juice, biofeedback, and other relaxation techniques. Homeopathy, flaxseed oil, and there are some herbs that are also can be very effective. There are many different types of laxatives and there are different types of fibers. So what you just want to do is just run it by your doctor at some point so that you know that you are taking the right product. But I do have a tendency of recommending polyethylene glycol, which the trade name is Miralax, because I just find that it tends to be a bit more gentle. But all of the laxatives, you do need to stay well hydrated. So please keep that in mind. And we've got some other medication options as well, which I won't go through all of them, but they're there for you. Let's talk about diarrhea. Um, this can be really distressing and exhausting. Unfortunately, there are some things we can do about diarrhea. Um, I will say, though, however, that there are some times when we need to encourage diarrhea. And for example, we have an infection called Clostridium difficile, also known as C. diff. And if you get this infection, which is going to become more common when you are immunosuppressed, and advanced disease is a time where that's common, C. diff, we actually need you to get it all out of your system. So we don't want to be stopping that diarrhea too early. So just keep that in mind. But when there is diarrhea, we also really want to consider skin health and what we can do to protect the skin. So what can we do to help with diarrhea? Here are some of the herbal non-pharmacological options: slippery elm, aloe vera juice, carob powder, probiotics, fermented foods, bland foods, electrolyte fluid replacements, some teas, oversteeped black tea. We have some medications that in particular are anti-diarrheal. And not on this list, but like I said, skincare is really important, and we might want to add Vaseline or diaper rash cream to help protect the skin. Dry mouth, also known as xerostomia, this is unfortunately common in advanced disease, and there can be a lot of sources for it: dehydration, poor circulation, breakdown of the glands, too much bacteria, a medication side effect, and it can be infection. If it's infection, we want to treat it. But if these are some of the things we can do if it's not an infection-based source. If it was an infection, we'd go for antibiotics. But when it comes to dry mouth, herbal and non-pharmacological interventions, warm tea and lemon, mouthwash, increasing fluid intake, acupuncture, lip balm, artificial saliva products. There are mouthwashes that have artificial saliva in them, and those are the ones I tend to recommend. I don't tend to recommend regular mouthwash because for a lot of people it can be drying, sometimes that alcohol in there. But if it's working for you, that's great. Just keep going. Don't worry about it. Swabbing with glycerin, some food types as well, and we do have a few medications. Fatigue. So fatigue is when resting doesn't get rid of the exhaustion. We have a lot of sources, and I'm starting to run out of time, so I'm going to move a little quickly. But I'm going to highlight that, sleep hygiene, like I discussed earlier, can be incredibly powerful, but you do need to be very consistent about it. Surprisingly, exercise has been known to help with fatigue because it helps bring down the inflammatory response inside the body. social engagement, breath work, yoga, all of these many things. And we do have some medication options as well. And our palliative care doctors tend to be good at focusing on fatigue and how to help with that. Hiccups. The only thing I will say with hiccups is that fortunately it's rare. It doesn't happen a lot, but I have seen it. And there are things we can do. So if it happens to you, I'm very sorry, but we have things we can try. So please let the doctors know. Itchiness, pruritus. There's so many sources of potential itchiness, and it can become chronic. So what can we do about it? There are herbal and non-pharmacological interventions like light therapy, specifically UV light therapy, depending on the source of the itchiness. That can be really powerful. We've got different moisturizers and lotions and topical things. Cool environments are going to be helpful. Colloidal oatmeal baths, and we also have different medication options listed on the side. Loss of appetite, cachexia, wasting. This is when you can become very, very thin. And this term, you might have heard muscle wasting. Some people say that it's like somebody becomes a bag of bones. And this can be so, so hard for everybody. Food is often an emotional topic during the end of life. It's really like this involuntary weight loss. And what we find is that cachexia is often not reversible. We will try, and not that it's completely unreversible, but oftentimes cachexia, especially in advanced disease, starts to become a process of the body shutting down. So rather than it causing someone's death, it's more about just the body no longer being able to use the nutrients that are coming in and becoming really efficient to the very end, using everything that it can. Uh, and so it can be incredibly stressful, but there are things we can do. Repositioning to improve the comfort of swallowing, adding fat to the diet. If you don't feel like eating, but you can still chew, savor, and spit. You can cook for that scent or symbolism, or just to have that process of being with family, even if you don't want to eat it. Eating for pleasure rather than for nutrition. You just eat anything you want to. Like, we do not care. Anything is good. Smaller portions and smoother textures tend to be better tolerated. Sweeter things also tend to be better tolerated as well. We do say please encourage, but don't force, because it's become something that someone can't really do anything about, or really can change. But we have medications that can be helpful as well. So please definitely talk to your doctors about those things, although the medications aren't likely to actually reverse the process. Nausea can be so many different sources and can be caused by other medications and other symptoms that are not well managed. We want to keep in mind that our mucosa lining, our gut, starts from inside our mouth, down our esophagus, through the stomach and the intestines, all the way out the rectum. And so all of these things are affected together. And that's one of the reasons why it's such a common symptom during, cancer treatment. And what are some of the things we can do? We have a ginger, peppermint, chamomile, fennel tea, sparkling water and grapes, acupuncture, acupressure, the anti-nausea wristband. Some people have had great luck with. We have some wonderful medications, which we're so, so thankful for. Our nurses actually talk about pre and post Zofran era, which is a specific an anti-nausea medication that has made a huge difference. Pain. We have both musculoskeletal and neuropathic sources of pain, and cancer pain can be from across the spectrum. But I do want to make a quick word about neuropathic pathway of pain, which is highlighted in this picture here, because it is, or actually this is more muscular, but neuropathic pain is something that can be caused by the cancer itself or the treatments that we are giving. And it is one that is a little bit more unique to cancer. It's not as common outside of cancer. And there are specific treatments for neuropathy. That is different than for musculoskeletal pain. So you do want to have that discussion with your doctor, and they should be on the lookout for that. Uh, so what can we do? Cold, heat therapy, acupuncture, biofeedback, behavior modification. We're like, hey, we're going to try everything. And if we can't do something about the physical part of it, pain has a very important mental and emotional component attached to it. We'll attack it from that area. We will go from any angle that we can. Animal assisted therapy, transcutaneous electric nerve stimulation, music therapy, meditation therapy. When I go back to music therapy, there's specifically a vibration music therapy that some people report as being very, very helpful for their pain. So keep that in mind. We talked about some, psychotherapies, touch, and like the herbs as well. Lots of different herbs that some people report have been effective, and we have lots of different medications. Each of these medications act differently and affect different sources of pain. And so, of course, always under the direction of a doctor. But we have tools, and medication becomes extremely important, especially at the end of life and advanced disease. Shortness of breath, this is dyspnea, air hunger, where even if your oxygen saturation is normal, you feel like you're short of breath. And there is this really important feedback loop between shortness of breath and anxiety, because when you are short of breath, you naturally feel anxious. And when you feel anxious, it makes you more short of breath. So you'll see that some of our treatments are going to attack from both angles. So ambient airflow positioning, there's this tripod position where somebody is leaned forward on two arms, a forward bending over, that can be really helpful, and was the position my mom was in for a lot of the end of her advanced disease. She had cancer. Acupuncture, breath work, ambient essential oils like eucalyptus, peppermint, frankincense, citrus, lots of options, psychotherapy, music therapy, and we have medications that can help as well, including oxygen. Skin breakdown. This one, we really want to do our best to prevent as much as possible. And towards the end of life, it may not become possible to prevent everything, but everything is about prevention and caring for as much as possible. So let me move on quickly. Taste changes. This is common in advanced illness, and it can be very distressing. But what can we do? What we do is we work with the taste functions that remain. So if something is tasting too sweet, we can try to add some sour notes to it. If something tastes flat, add sour, add sweet. Too sour, we can go ahead and add fat or add sweetness. Something tastes too salty, add sour. Too bland, add sour, add salt. Too bitter, add sweet. And like I mentioned, sweetness is considered one of the kind of primitive taste profiles because it's one of the first that develops, and it's often thought of as the last to go. And so, if anything, that's what we try. Okay, so timeline for symptoms during the end of life. This is not prescriptive. This is, everyone is a unique individual. These are just some things that we have a tendency of seeing. And the weeks before death, we often see social withdrawal, becoming much more introspective, increased sleeping, decreased appetite, weight loss, fragile, easily damaged skin, unfortunately increased general pain. That's why we also focus on managing that. Days before death, we'll start to see drops in blood pressure, changes in skin color, cooler hands and feet. These are all sort of the signs of the body kind of shutting down. Fewer bowel movements and urination, decreased appetite and fluid intake. There can be something called the death rattle, where the body starts to accumulate secretions so that when someone breathes, it has this sort of raspy, rattling sound. We actually don't have any evidence that the death rattle bothers somebody who has it. But if anything, it tends to be very distressing for the people around the person with the death rattle. And so in the hospital, we would often try to treat it by drying out some of those secretions. But when the death rattle appears, the average time of death is 23 hours. So it does tend to be a harbinger of death coming. Delirium and hallucinations start to become more common as well. And the day before death, sometimes we get a sudden burst of energy and it is beautiful. And if it happens, please enjoy it. But please keep in mind that it can be a part of the dying process. We have patients and family that get really excited saying like making plans for the future and then are very disappointed when the patient ultimately passes. So if it happens, please enjoy it. Skin becomes increasingly mottled and blotchy as circulation dies down, further drops in blood pressure, inability to swallow, less urine, and increased restlessness, labored breathing, increased congestion, including possible fluid secretions, kind of related to the death rattle, hours before death, glassy, teary eyes that may be half opened, cold hands, weak pulse, increased hallucinations, sleeping and unable to be awoken. Breathing is interrupted by gas or may stop entirely. There's something called agonal breathing where there's this like deep breath and then this pause without breathing for a season and then another big breath. So those are some of the things that we see. And how do you know when your loved one has died? Well, certainly cannot be awakened. Breathing stops, and you check that by putting your hand up to the mouth or the nose to feel for breath. Some people put a mirror to see it if it fogs. You can check for the pulses, over at the radial pulse at the neck. Um, you will see that the eyes and the mouth will naturally open when somebody dies. And so in the hospital, we would actually purposely close patients' eyes and we would actually tie a ribbon so that the jaw would shut. And then when the body freezes in what's called rigor mortis, the patient would kind of be preserved in a position that looked more comfortable. Um, so I rushed through that super quickly, but um, thank you for bearing with me. I just wanted to end with this quote from the great Cicely Saunders, who was one of the champions of both palliative and hospice care. Says, "You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die." Because as much as this talk was about dying, the end of life is actually mostly about living. So here are my references, and I'm going to open it up for questions. Let me see. Ta-ta. Sorry, Abby, can I ask for your assistance?
No worries. Yeah. Thank you
Yeah.
so much, Sarah, for your very meaningful presentation. We do have a couple questions in the Q&A, so I'll go ahead and start with those. Someone in the Q&A said, I am attending as a master's student for clinical counseling to become a therapist. Are there any resources or advice you can give for someone like me who wants to help those towards the end of life or towards the end slash their families?
Oh, yes. One of I think, sort of the easiest recommendations I could make is actually read that book that I recommended. It's a wonderful resource. There are also some other really great resources that, like, they're not coming off the top of my head at this moment, but if you reach out for my contact information, I can send you. There's some really great really great resources.
Perfect. Thank you so much. And then someone else asked, what are interventions for muscle wasting, weight loss, and lack of appetite?
So, unfortunately, we don't have a lot of interventions. What we do like to do is to try to intervene as early as possible. We like to try to prevent the patient from actually getting to that stage of cachexia. Um, and so our nutritionists will come in, they'll look at, how we can optimize your nutrition and your diet and look at all of those things to kind of like shore as much as possible. Uh, I will say that I am very, very excited that there is some early phase research about a medication that it targets a specific gene, and for certain patients who have this gene, it actually will prevent cachexia and can actually reverse it, which is crazy. But this is early stages. We have a lot far to go, but I'm very excited about that and the potential for the future.
Perfect. Thank you so much. There are also just some comments in the chat thanking you for your wonderful presentation. Someone is asking, can you share the last two slides about signs of dying and after?
Oh, of course. Here, let me go. Let me share my screen. Did it work? No, not yet. Okay. So I'm thinking perhaps these slides might be the ones that you would see. I did not mention, but a fascinating thing that we see and hear about towards the end of life, especially towards the very end, are people making recitations of things that they learned when they were very young, whether they're like religious or otherwise. So I just thought I would mention that that's something that we tend to also see. Uh, yes, if there's any questions about more about this, please let me know.
Thank you. We did receive a couple questions um, uh, during registration, so I can go ahead and ask. We have time for one more question. But someone asked, how can you prepare loved ones and family members, including young children, for someone's imminent death?
Oh my goodness. Yes. That is a very hard question, but one that I love that you asked because unfortunately, I don't think not most, there are many people who don't think through it. But the fact that you are asking and think through it is actually very powerful because there's actually a lot of things that we can do that a lot of people don't realize till after the fact that would have been very meaningful. And for that, I will say we have the part of our talk that was the social worker's perspective, and they went through some of this legacy planning and things that families can do together and ways to have the conversation that can be really just helpful. So I'd invite you to take a look at that one.
Perfect. Thank you so much, Sarah, for taking the time to be here with us, for sharing such a meaningful presentation. And just, yeah, thank you for everything. We do have one final closing slide that I would like to share. Um, so again, thank you everyone for joining us. If you would like to learn more about Cancer Support Community Los Angeles, please visit our website at cancersupportla.org. On that website, you will also find our video library that has the video that Sarah mentioned. So you can feel free to take a look there. And then if you have any questions, please feel free to email us at info@cancersupportla.org. And I just wanted to share one of our online classes that we offer. We do have a mindful self-compassion class that meets online every Wednesday from 5:15 to 6 p.m. And you can go ahead and scan that QR code to take a look at our calendar, and you can go ahead and register through there. But thank you again, everyone, for joining us and for being so engaged today. And Sarah, thank you one last time for spending your time with us today. And we
Oh,
hope
my
to,
pleasure.
yeah, thank you so much. And we hope to see you all at a future webinar. Bye.